to retreatment.
Mm, I guess we have 2 minutes to go, right?
Yeah.
Okay.
Firstly,
And who is that?
I need to introduce you to the audience, and then you can
Definitely.
start.
Let's wait for the next 2 minutes because I guess people has a reminder on the Instagram story and everything.
Yeah.
Hmm.
Is it your first time with Google Meet webinar?
I actually use Zoom more.
Zoom? Mm, I
Hmm.
see.
But this platform looks very simple.
Yeah.
Mhm.
Okay, I think it's time. So we can start. So firstly,
Yes, let's
let me
start.
let me introduce you to the participants. So hello again, Dr. Khalid Khalifa. So uh, today is our pleasures that we have you to share your presentation and about simplify endodontic workflow from primary treatment to retreatment. So I want to introduce Dr. Khalid also. He is a silver member of Style Italiano Endodontics and also a professional master degree in endodontic and microsurgeries. And Dr. Khalid is a speaker and course director of endodontics. So the webinar is yours. You can start your presentation, Dr. Khalid.
Thank you so much. It's a pleasure, and thank you so much for D Perfect for allowing me the opportunity to present a really nice lecture. It's going to be very clinical, and it's full of clinical tips and tricks. As per your request, I'm going to talk in English slower so everyone can understand me well. Our lecture is going to be very interesting. It's going to be a long one. That's why we suggested to record the lecture because I'm pretty sure you're going to want to hear it multiple times. Our lecture is about a simplified endodontic workflow, either in root canal treatment or retreatments. Let's start. Why we are doing this lecture? Because now we have many opinions and protocols in endodontics, and it started to become a little bit complicated. That's why I decided to do this lecture to make it more simplified, um, and advanced at the same time, to allow you to have a predictable workflow in root canal treatment and retreatment. By the end of this lecture, you will be able to do a predictable and efficient root canal treatment and retreatment as well. Understand the different motion and kinematics regarding your rotary device. Now we have many motions and it's quite complicated for many people. That's why I came up with a protocol that is going to be very simple and is going to allow you to do a predictable root canal treatment and retreatment in a very efficient way. And we're also going to talk about the irrigation and obturation protocols and the difference between root canal treatment and retreatments. All is good. You can hear me well, right? Perfect. Okay, let's start. So we're going to start by the root canal treatments. And intentionally, I wrote simplified root canal treatments. Okay, because we're going to share a protocol that is simplified. And believe me when I say it, it's going to manage most of your endodontic cases, including the advanced ones. I won't jump immediately to the shaping protocol because the shaping protocol and any root canal treatment starts with a proper access cavity preparation. Access cavity preparation is the most important clinical step in endodontics. It consists of making complete deroofing and straight line access. If you did complete deroofing and straight line access, you save many iatrogenic errors that can happen. For example, if you did underextended access cavity preparation, you might suffer from broken instruments, ledges, and missed anatomy. And if you did overextended access cavity preparation, you're gonna be lost searching for the canals, and you're gonna suffer as well with massive loss in tooth structure, and it's gonna weaken the tooth. So basically, we have many concepts of access cavity preparation. We have the traditional, the conservative, we have the ninja and the truss access. The studies have showed that it doesn't do a significant difference of doing ninja and truss. Okay. So I will go for traditional and conservative access cavity preparation and having a straight line access to the canals. Okay. Where is the location of the pulp chamber? This is a very important question. The location of the pulp chamber is always located at the center of the tooth. A law of centrality by Krasner and Rankau, they said that the pulp chamber is always located at the center of the tooth at the level of the cement-to-enamel junction. So basically, any tooth, if you decided to go in the middle, the center exactly of the tooth, and go deep to the level of the cement-to-enamel junction, you will always find the pulp chamber. And from this point, you simply move lateral to the roof of the pulp chamber, and after it, the access is going to be complete. You don't go and draw a predetermined shape on your mind. You simply de-roof the pulp chamber, and you're going to find the shape of this specific tooth. And this will explain why, if you opened access in, let's say, for example, 20 upper molar, you're going to find each one has different shape, because the teeth, they come with a shape of their own. It's not a preconceived shape. You go and draw it. That's why the most predictable way to open an access is simply to go in the middle of the tooth at the level of the CEG. And you can determine the level of the CEG by a periodontal probe before starting. And this is very important, actually, to determine the depth you're going to go. Because simply the depth differs from a tooth than another. Some teeth have recessed pulp chamber. Some teeth are already reduced for a crown, for example. You won't need to travel a huge distance. And some teeth, they have attrition, for example. So every scenario is a little bit different. After de-roofing and opening the access cavity preparation, you're going to start by locating the orifices of the canals. The orifices are going to be located by an endodontic probe, something like DG16. You shouldn't detect the orifices by a manual file, because the orifices, they have pulp tissues and collagen fibers and stuff. Sometimes the manual file will bend and break at the beginning of the orifice. So it's better to detect it with a sharp endodontic probe to pierce the coronal 2 to 3 millimeter of the canal. The orifices of the canals, they follow laws. Just like the law of centrality, we have other laws. For example, law of symmetry. Law of symmetry can be applied on all teeth except the maxillary molars. It says simply that the orifices of the canals, let's put an example of an upper four, just like in this tooth. The orifices of the canals are equidistant and perpendicular, meaning that they are on the same line and the same distance. If you divided the tooth mesiodistally, you're gonna find them on the same line and on the same distance as well. For example, if you found the buccal canal in the upper four and you can find the palatal canal, you simply draw an imaginary line dividing the tooth mesiodistally, and you search on the opposite side on the same distance and the same line. We have laws. For example, we have the wall-floor junction law. This is a very important law, meaning that simply the canals will be located at the line angles of the teeth between the junction, between the floor and the wall. The dentine map is a very important line. It's a very important law. The dentine map is the black lines. You will find them at the floor of the tooth. That's why it's very important not to touch the floor by any burr, because you're gonna erase it. The orifices of the canals are situated at the ends of these lines. They are called also gray tracks. And the final law we have is the law of color change. Under magnification or even by your eyes, under proper illumination, you can clearly see that the color of the pulp chamber is darker than the dentine of the tooth. Okay? After finishing the access cavity preparation, by the way, we're gonna have a video showing all the steps of the root canal from access cavity preparation to obturation. After opening the access cavity, now we're gonna start by the instrumentation. Today we will be talking about an advanced way of instrumentation. That's why you need to be equipped. Rotary devices now are not simply rotation and separate apex locator and separate rotary device and everything. Now we actually have recent advancements in our rotary devices. For example, the Endomaster device and many other devices, they have built-in apex locators. And this is actually how I do my work now. I do my work manualless without using manual file and by the help of an integrated apex locator within the endomotor. It helps me in many things. For example, if you used a separate apex locator and you took the working length at the start of the case, actually the working length changes after each rotary file you use. For example, after the orifice opener, the working length changes. And after finishing the complete shaping protocol, the working length actually changes as well. That's why the integrated apex locator helps me out, because it keeps changing with me during the whole procedure. The tiny difference in few millimeters, 0.5 millimeter and everything, it helps me out not to make errors and keep on doing the shaping on a reproducible working length. But however, doing the root canal purely manualless without introducing a rotary manual file requires a high level of tactile experience. So if you don't have this tactile experience and you're still new doing the manualless shaping, I would recommend that you use a file manual 10 only for scouting and for initial glide path, then continue the full case with only rotary files. And this is how I'm gonna show it to you now. I'm gonna show you a protocol that will make your root canal very fast and very predictable, and it's gonna minimize the errors. Okay, we're gonna demonstrate it on MG3 blue files. And if you want to add extra level of glide path, I recommend that you use the gliders as well. So let's see the sizes we have. On the left, we have the MG3 blue files. The kit has orifice opener, a 15 taper 4 rotary file that we're going to use for glide path, a 20 taper 4 rotary file, and we have a 25 taper 4 and a 25 taper 6 that we're going to use according to the case. Okay? And we have finishing files. What does it mean? Finishing files are the files we're going to use only for apical finishing before obturation, like 30 taper 4, 35 taper 4, and 40 taper 4. On the other hand, we have the gliders. The gliders are very smart files for reproducible glide path. The most favorite file for me is the 10 taper 5. This file is genius. This file is genius, especially in MB2. We have also 13 taper 45 and 14 taper 35. You don't have to use all three files, by the way. You can use only one file or two files. I personally use the 10 and the 13 before introducing the 20 taper 4. So let's put the files and the motion and kinematics into our shaping protocol. How to take advantage of the recent advancements in motion and kinematics to have a predictable shaping protocol that is very safe and is going to reduce your iatrogenic errors. So we're going to start first by coronal flaring. Coronal flaring is by introducing the orifice opener. We have a little bit of a dentine shelf, as you can see in the photo on the right. This part blocking the orifice, we need to make a straight line axis. After making a perfect axis and a straight line axis, we still have this part to deroof it. Okay? So we're going to introduce our orifice opener and do something called anti-curvature filing. Anti-curvature filing is by simply introducing the orifice opener for few millimeters and do a brushing motion on the outer wall. In order to make it easier for you, the outer wall has the same name of the canal. For example, if you are introducing the orifice opener in a mesiobuccal canal, you're gonna do a brushing motion on the mesiobuccal wall, okay? We're gonna use it on a high speed, for example, 400, and a high torque as well, okay? And on continuous rotation. The continuous rotation is the classic motion of the rotary devices we use in order to make a straight line axis. Here you can see the motion. We're gonna introduce the file and we're gonna do brushing motion on the outer wall. It's gonna remove this part of dentine covering the canal. As you can see, now the file was going with an angle and it has a straight line axis. As you can see here in the X-ray. Now it has a straight line axis after removing this part of dentine covering the orifice of the canal. This is actually the first curvature in the canal, meaning if this tooth has multiple curvature, by this method, you eliminated the first curvature in the canal. Okay. The second step is by making a reproducible glide path. Here, we're gonna start by changing the protocol everyone knows, okay? I only use continuous rotation in my orifice opener. Then I start changing it by using ATR. ATR is the adaptive torque reverse. And SSGP motion is a glide path motion integrated in the endomaster device. We're gonna explain everything now in a predictable manner. First of all, the ATR motion is simply the rotary is gonna proceed in a rotation kind of manner. And when it has excessive stresses on the file, and it turns into a reciprocation motion. Reciprocation motion meaning that the file turns into an angle clockwise, then a counterclockwise angle. For example, it turns into 150 degrees clockwise, then 60 degrees counterclockwise, 150 degrees clockwise, and 60 degrees counterclockwise. This is a reciprocation motion. And after the resistance fades away, it turns back into rotation motion. Let's make a comparison between reciprocation and rotation motion. Rotation motion is faster. It cuts more inside the root, but it's riskier of the file getting unwinded or being broken. Okay, the reciprocation motion, on the other hand, is slower, safer, and keeps the file centralized inside the canal. The ATR motion combines the best in both techniques, using the rotation of the clockwise, the normal rotation motion, and when we have stresses, it switches into a reciprocation motion, dealing with this specific part, excessive torque in this specific part, to unlock the file and keep it safe and centralized within the root canal using reciprocation motion. And after the resistance fades away, it turns back into rotation motion. So it combines both, the best of both worlds, using the rotation and reciprocation in one motion. It's called ATR motion, and in other devices you can find it under the name of OTR, ATC, whatever the device. Okay. The SSGP motion is another kind of motion. It's a motion designed purely for glide path, where the device turns into 4 cycles clockwise and 4 cycles counterclockwise. I'm going to show it to you right now. So in scouting, using the glide path rotary files, we're going to use either of these motions, okay? And starting from now till the end of shaping, we're going to use a high speed, like 500, okay? And a very minimal torque, starting from 0.4. 0.4, why? Because I want the device to be extremely sensitive to any changes in anatomy. For example, if the file entered in a curvature or anything, it's going to trigger the reciprocation motion. Okay. If anyone got word that we are using a high speed, rotational speed, actually, when you use a high speed rotational speed like 500, you maximize the lifespan of your rotary file, not the other way around. Because now the file, in order to reach the full working length, it goes away in 1, 2, 3 strokes maximum. And it decreases the debris accumulation in the apical part. If you put the speed on 300, thinking that this way is safer for you in shaping, actually, you are putting more stresses, more cyclic fatigue on the file, you are putting more contact area on the file and contact points, and you are reducing the lifespan of the file. Your file is actually going to be more unwinded, not less. And you're going to increase the risk of fracture. So it's better to increase the speed and decrease the torque. This way, you're gonna make your file have more lifespan, okay, and progress normally in the canal, okay. And actually, something I noticed very in my clinical practice, when you do this, you decrease actually the apical blockages and the debris accumulation in the apical part, okay. We're gonna add file 10. Yes, we're gonna add file 10 if you're not 100% or even 80% sensitive to the tactile sense using the rotary device. So we're going to add file 10 for scouting and for glide path before introducing the rotary file glide path if you're worried of using the case completely manualist. And I advise people to use the case manualist, to try first using manualist preparation on many extracted teeth to have the tactile sense before doing it on a patient, okay? Let's start talking about every part in particular, separately. The scouting and the glide path. The scouting and the glide path using file 10, you start by pre-curving your file 10 and do short strokes, vertical strokes, watch winding motion, left and right, quarter turn right, quarter turn left, with slight apical pressure. Okay, and you proceed slowly in the canal, as you can see in the video. This is actually the motion we do. And you get out the file, clean it with a piece of gauze with alcohol, okay? And you do irrigation for lubrication and to clean out the debris. This is how we do the scouting. The scouting with a stainless steel file 10 is going to show you the curvature inside the canal. It has a replica inside the canal. And at the same time, it's going to prepare the canal before introducing the rotary file. In case if you don't want to do it manualist, okay? You should do it till the file is completely loose after reaching the full working length. The SSGP motion, the one I told you, is simply a motion, a reciprocation motion of a clockwise motion, 150 degrees, and counterclockwise motion, 60 degrees. The device is pre-systemized. It's a pre-systemized, built-in motion on the device, okay? The rotary file is going to do exactly like this. It's going to do 4 cycles like this. It's going to do 4 cycles, 150 degrees clockwise. It's at 150 and returns counterclockwise 60. Then 150, returns 60. 150, returns 60. 150, returns 60. 4 cycles. Then it, it's going to do the same motion in a reverse kind of motion, counterclockwise. It's going to do counterclockwise 150, then proceed 60 clockwise. Okay? Another 4 cycles. So this motion is a really safe motion and it's guaranteed. It's going to be perfectly safe for your glide path file. The only bad thing in this motion that it's super slow. It's super slow. Slow, but very safe. And it's purely reciprocation motion designed only for your glide path files. Because it doesn't make sense that after you do it, you do the shaping with it as well. So the SSGP motion is designed for a reproducible glide path without damaging your rotary files. Okay? And also this motion, in order for it to cut better, please place it on 500 speed. Okay? This is the motion you can see now. The ATR motion, as I said, is a continuous rotation motion. Okay? Then when the file continuous rotation and when the file suffers resistance, it turns into reciprocation motion. Okay? Then after the resistance fades away, it turns back to a rotation kind of motion. Let's see here. So basically, you can do the glide path motion on SSGP, which is the safe glide path kind of motion, or you can do it on ATR motion. ATR is going to be faster and it's going to cut more efficiently. Okay? In case you wanted to make it faster a little bit during the shaping of the glide path files. So in the glide path file, we are going to use gliders, or we are simply going to use the 15 tapers 3 included in the kit of the MG3 file. Okay? After doing this motion, we simply have now a reproducible glide path inside the canal. A reproducible glide path inside the canal is very, very useful because after doing a reproducible glide path, believe me, it's very hard for you later to do an error in the canal. It's very hard to do a ledge. It's very hard to do apical blockage, for example, if you're doing it using a built-in apex locator dual function device. And it's also advisable to keep your 10K file always available to do patency between each file and do irrigation, okay? Regarding the shaping protocol is gonna be done using only ATR motion. Doesn't make any sense to do it on SSGP motion anymore. We're gonna do it on ATR motion on a high speed, 500, and also the torque ranging from zero point 0.4 to 1.2. Okay. The shaping files are 20 taper 4. This file is gonna be introduced in all canals. This is the universal file we're gonna use in all canals. The next file is 25 taper 4 or 25 taper 6. Let's talk about when to use 25 taper 4 and when to use 25 taper 6. Okay? 25 taper 4 is very conservative. However, in cases like a palatal root upper 6, a distal root lower 6, even premolars when they are single, large and oval canals, it's better to use taper 6, 25 taper 6 in order to ensure that you mechanically touched all canal walls in order to shape it in a proper way to allow irrigation to clean the canals. Okay? So I recommend that you use 25 taper 6 if the canal permits, and it's contraindicated to use it in canals like MB2, in C-shaped canals, in severely curved canals, in roots in preoperative X-ray. If you notice that the root is thin, it's better to avoid. Thin, I mean when you look at the X-ray and you find the root mesiodistally thin, it's better to avoid 25 taper 6 in order to avoid any strip perforation. Okay? So according to the root and the canal we have, we're gonna finish the shaping by 25 taper 4 or 25 taper 6. Then we have the finishing files, 30 and 35 and 40. These files are gonna be used in the large canals, like palatal canals, or even in the mesiobuccal canal, mesiolingual canal, if they are big and preoperatively, they are big enough, okay? It's advisable to use them, but sometimes we shouldn't finish the shaping on 25 taper 4 only. This is a preoperative assessment and a clinical decision we take according to the case. For example, if you compared a mesiobuccal canal, lower 6, on a patient who's 20 years old, and you compared the same canal in a patient who's 60 years old, you're gonna have that the patient with 60 years old, the canal space is gonna be reduced and the apical part of the canal is gonna be reduced. So in his case, sometimes the 25 taper 4 as a final finishing file is more than enough. But a patient, for example, who is 20 years old, the canal is already large enough and has a huge amount of pulp tissue. If you finished it on 25 taper 4, this way you're gonna have an obturation filled with pulp tissue, remnant pulp tissue. So you need to increase the apical part up to 30 and 35 and sometimes 40 in order to ensure 100% that the apical part is clean enough before doing the obturation. So choosing your finishing file depends purely on many factors, including is the tooth is vital or not, the age of the patient, the root is straight or curved or not, because sometimes we have a severely curved canal and it's very risky to go beyond, for example, 30 taper 4. And we depend more on the irrigation and activation. So basically, the shaping protocol depends mainly on, it's not something pre-systemized. You shouldn't memorize this canal, it should be done on 40 taper 4, for example. It's a decision you take actually clinical, looking on many factors, like the tooth is vital or necrotic, for example. Many factors are very important to be included in choosing your finishing file. Let's see here the ATR motion. You're gonna see here that the file is going on a continuous rotation. Then it fades away, reciprocation when it meets resistance. You can see here the rotation, and it turns into reciprocation when there is enough resistance on the file. Okay, and as you can see, each roti file each rotary file doing instrumentation inside the canal, our lubricant is sodium hypochlorite. We fill the tooth with sodium hypochlorite as our lubricant. We don't use any editor gel inside. Let's start our irrigation protocol. After finishing the complete shaping of the case, we start our irrigation protocol before obturation. Why do we do irrigation? Because after doing the complete shaping and the irrigation we do inside the shaping, it's not enough. The instrumentation only cleans 70% of the canal system, and we have to do an irrigation protocol and activation to maximize our success rate. The hydrodynamics of irrigation is very important to pick an irrigation needle with a gauge of 30 to reach the apical part. As you should know that the irrigation needle, the flow of the irrigation doesn't proceed more than 1 millimeter after the irrigation needle. That's why you should pick a 30 gauge needle in order to reach as far as we can go in apical part of the canal. And you should make sure it's not locked inside the canal, because if it's locked with your pressure, it's going to do a sodium hypochlorite accident. And you should use a double vented needle. Okay, I prefer the double vented polymer tips for it to go through the entire root canal system, because most of the canals have a little bit of curvature. Okay, the irrigation solutions we use are sodium hypochlorite. We use EDTA, EDTA, for smear layer removal, and we use chlorhexidine as well. Okay, I personally rely more on sodium hypochlorite and EDTA, and chlorhexidine I use it very rarely in retreatment cases. Okay, so let us talk a little bit about our irrigation solutions. Our gold standard is a sodium hypochlorite, because it's the only irrigating solution that dissolve organic tissues, which is the pulp tissues. Neither EDTA or chlorhexidine have the tissue dissolving capacity. That's why the sodium hypochlorite is the gold standard of irrigants. And it also allows us for lubrication effects. That's why we use it as well for lubrication. And I use it in full concentration, actually, 5.25, to maximize the disinfection and the tissue dissolving capacity as well. The EDTA, the EDTA, is used for inorganic removal of the inorganic component inside the canal, which is a smear layer, which is something that the sodium hypochlorite cannot do. And after removing the smear layer, we need again sodium hypochlorite to clean the open dentinal tubules of bacteria and everything. Because sodium hypochlorite is the most potent antibacterial solution we have. EDTA, they have minimal antibacterial effect, just like the citric acid as well. We have EDTA and we have citric acid. Citric acid is around 30 to 40%. EDTA is around 17%, and you can use any of them. It's not a significant difference. The chlorhexidine has something called substantivity. Substantivity meaning that it adheres well on the dentinal tubules and it stays releasing antibacterial action for a prolonged effect, for a prolonged time. That's why we use it. It's very effective in retreatment cases for a specific strains of bacteria. Okay. However, I personally use it in retreatment cases only. I don't use it in my conventional root canal treatment or even straightforward retreatments. I use it when I have a resistant kind of infection, kind of retreatment case. I rely on it more. Okay. The interaction between irrigants are a massive important when you use sodium hypochlorite after chlorhexidine. Because if you use sodium hypochlorite after chlorhexidine, you're gonna have something called sulfur precipitations. You're gonna have a red color coming inside of the canal, and it's carcinogenic and it precipitates beneath the root canal, beneath the apex of the tooth. So it's very important that after using chlorhexidine, okay, actually we use the chlorhexidine as a final irrigant. So if you use it after using sodium hypochlorite, you should put a lot of saline and irrigate with a lot of saline inside the canal to make sure that there is no remnant sodium hypochlorite before putting the chlorhexidine as your final irrigant. And by the way, the chlorhexidine as your final irrigant can increase your bond strength with sealer, especially the resin sealer. If you're gonna use EDTA and sodium hypochloride, I don't want to overcomplicate the endo by putting saline between them. You can simply use microsuction to remove the sodium or the EDTA before introducing the other irrigant. But if you're gonna use chlorhexidine, it's mandatory to use saline to make sure you removed all the remnants of sodium hypochlorite. Okay. So the irrigation protocol I'm using in our daily root canal treatment is sodium hypochlorite the whole visit. Actually, the whole visit is average 30 minutes. We are using the sodium hypochlorite from the first case till our irrigation protocol at the end. So it's about 30 minutes. 30 minutes of sodium hypochlorite irrigation during instrumentation and flushing and between files and in our irrigation protocol. This is a good enough time to dissolve the pulp tissue. Then after finishing our 30 minutes visit, we're gonna use EDTA for 2 minutes after the complete cleaning and shaping, and you can activate it as well. And after activating the EDTA for 2 minutes and doing irrigation for EDTA, then you're gonna flush the entire root canal system using sodium hypochlorite. You can use activation. Yes, you can use activation. And personally, I prefer either sonic, ultrasonic, or intracanal heating. By the way, take care the intracanal heating is only with sodium hypochlorite, because if you did intracanal heating with EDTA, you're gonna ruin the crystalline structure of the EDTA. So you're gonna only use intracanal heating with sodium hypochlorite, and it's very, very effective. You're gonna see now in the videos. Sonic and ultrasonic, both of them are really good. Passive ultrasonic motion is better. However, it has anatomical limitation because the tip of the ultrasonic sometimes is rigid and it doesn't go through the curved canal anatomy. Okay, so sonic with the polymer tip, you're gonna see now in the videos, can go through the anatomy of the canal. Here you can see the red tip is the polymer tip. You can see it's gonna go as far as deep as we want. That's why it's better to put a rubber stopper on our polymer tip. This is the sonic activation. The ultrasonic tip doesn't proceed as much. That's why it has a little bit of anatomical limitation. And we want our activation devices to be less than the apical part, less than the working length by 2 millimeters. This one is reaching almost half of the root. That's why a polymer tip and sonic activation is better in these cases. Okay, let's start by the obturation techniques. Obturation is very simple. The concept of obturation is to provide a 3D seal and to maximize the amount of gutta-perca more than the sealer inside the canal. Okay? The concept of the obturation is simply by doing a coronal seal and the apical seal and entombing the rest of the bacteria inside the canal. Because believe me, even if you did the perfect irrigation protocol, the perfect shaping protocol, and you did everything right, there will be still some bacteria inside the canal. You have to entomb them by your obturation technique. That's why we rely more now on bioceramic sealer and high pH to help our obturation to reach the maximum result. When to obturate? Simply, nowadays you can obturate in a single visit, except you have exudate coming outside of the canal or the patient coming with an extraoral or intraoral swelling. Even in the cases of fistula, you can obturate in a single visit. So basically, dryness is the key word in your obturation. If you can have dryness and absence of signs and symptoms of necrotic cases, like, for example, a systemic manifestation of infection, like a lymphadenopathy, facial cellulitis, intraoral swelling, these are the contraindications of obturation in a single visit. Okay? The sealers and techniques, we're going to talk more about the sealers now. I personally rely more on bioceramic sealers for many reasons. For high pH, because they are hydrophilic. If I can't achieve 100% dryness, in retreatment cases, sometimes you cannot achieve 100% dryness. These sealers can set in not a perfect dry atmosphere, okay? And they can also expand inside the canal, and they have a high pH, which is favorable for me, especially in retreatment cases, okay? With bioceramic sealer, we can do either single cone or hot modified technique. With resin-based sealer, you can only do a continuous wave obturation technique. Okay, single cone shouldn't be used with resin sealer, and it should be used with limitations using bioceramic sealer. Okay, so warm vertical compaction is basically by placing a master cone that has the same fit of of your final shaping size. Then you use the Getaperca cutter device to cut and leave only 5 mm to 7 mm apical part of the Getaperca, as you can see here. Then compact it, then backfill the canal system using the obturation device, using thermoplastic Getaperca. Okay? This technique is very reproducible, and you can use it using the resin sealer. Okay? Let's see here in the video. It's going to be an explanation of the warm vertical compaction, the continuous wave obturation technique. You should make sure that the master cone has a talk back. Here you can see the talk back inside the canal. Using the resin sealer, the canal has to be extremely dry. The system V tip has to reach to 5 mm shorter than the working length. We're gonna coat the canal with sealer. And resin sealers are the hydrophobic. That's why you have to make dryness, proper dryness before applying them. Then we're gonna need the Getaperca cutter device to cut the coronal part of the Getaperca and leave only 5 mm of Getaperca at the apical part. Then we're gonna need the plugger to compact the apical part of the Getaperca and make sure it's sealing the apical part properly. After making sure of this, we're gonna start injecting thermoplastic Getaperca over increments. And you have to touch the old Getaperca inside in order not to make an air bubble inside. Okay? And here is the first wave. That's why it's called continuous wave obturation. This is the first wave, and this is the second wave of injection. And you can notice there is no voids between the increments. This is very important. And this is how to achieve a 3D seal using resin-based sealers. Okay. Let's talk about the single cone technique. The single cone technique, you have to find a geta perca that has the perfect fit of your canal. I personally don't like to use a single cone technique in oval kind canals, like for example, a lower five canal, oval canal, which is large, buccolingually, for example. That's why it's a little bit risky to use a single cone technique, because here you are relying more on the sealer more than the geta perca. And even if the sealer is ceramic, still we shouldn't maximize the amount of sealer more than the geta perca. The concept of obturation is to use more geta perca than the sealer. So I would recommend using a single cone technique in a narrow canal, for example. You already shaped the canal and it was very narrow. So it took the shape of your rotary file and took the shape of your geta perca. This is when I would rather that you use a single cone with a bioceramic seal. But if the canal is large and wide and it has spaces, and you still insist on using bioceramic sealer, I would recommend that in this canal, you would use something called a hot modified technique. A hot modified technique is basically, here you can see in the photo, this is a cross section when we cut the root. You can find that the bioceramic sealer is closing the rest of the canal. This canal is not obturated entirely by geta perca. It's obturated by geta perca and sealer. The bioceramic sealer is good. It sets and it expands and it's really good. It's very hard to remove as well. But still, we want to maximize the geta perca more than the sealer. That's why we would go for hot modified technique in canals that cannot be obturated well by only single cone. Hot modified technique is a mixture between uh, applying bioceramic sealer, okay, and still doing a 3D obturation by geta perca. So it's basically the same as continuous wave obturation, but instead of leaving a 5 to 7 millimeter geta perca at the apical part, you only cut the master cone, the middle third of the root. This is the first uh, change. So, for example, if you have a canal 22 millimeter in length, if we're gonna do a continuous wave obturation technique using resin sealer, we're gonna adjust the rubber stopper of the heat carrier device on, for example, 15 millimeter, 17 millimeter, in order to cut very deep and only leave 5 millimeter at the apex. But if you're gonna do a hot modified technique, you're gonna adjust only the heat carrier at 10 millimeter, for example, to leave half of the geta perca inside the canal in order to avoid transmitting the heat to the bioceramic sealer at the apical part. Because bioceramic sealers are not that heat friendly. They are hydrophilic and they love the water content. If you applied heat for excessive amount of time or heat more than 150 degrees, you risk that you change the structure of the bioceramic sealer and it will evaporate the water content and will affect the setting time and the composition of the sealer. That's why if you want to apply a hot modified technique with your bioceramic sealer, you're going to do two modifications of the continuous wave obturation. The first modification is that you're only going to adjust the heat carrier to cut at the level of the middle root only. You're not going to go to the apical part. This is the first modification. And the second modification is to adjust the heat to maximum 150 degree. If you're using continuous wave with resin, I don't care. You can go as high as 250 degrees. The resin sealer can withstand the heat. Okay? Let's see here the video. We're gonna do a canal with single cone obturation, putting the bioceramic sealer and putting the master cone, and we're gonna cut the geta perca at the level of the orifice. And the other canal, we're gonna cut the geta perca at the level of the middle third. This is the hot modified technique. And we're gonna inject it till the coronal part using a thermoplastic geta perca. As you can see, the heat carrier only reaches the middle third of the root in the preoperative X-ray. We're gonna apply the bioceramic sealer. Take care, we shouldn't wedge the bioceramic sealer to avoid extrusion. It should be loose inside the canal. This is single cone obturation technique. We cut it at the level of the orifice. Here we're gonna try the hot modified. We're gonna go deep up to the middle part of the root, only the middle. We're gonna go to the middle part of the root, only 10 millimeter from the cusp tip. We're not gonna reach the apical part. Then we're gonna compact you can see here, we only to the middle part of the root. And the heat is only 150 degrees on the heat carrier. Then we're gonna inject, backfill the canal with thermoplastic gutta-perca. So it combines best of both worlds to satisfy you for using bioceramic sealer and at the same time filling the canal with more gutta-perca. So it's not a single cone obturation technique. You're taking the advantage of injecting gutta-perca and doing a 3D obturation and at the same time you're not disturbing the sealer composition inside the canal. So it's the best of both worlds. So I recommend that you use the hot modified technique if you are insisting on using bioceramic sealer, and at the same time, you want to make sure that the canal is filled with gutta-perca more than sealer. Okay? Now we're gonna have a video. Just want to, yes, exactly. Okay, this video is gonna show the entire steps of root canal. To summarize the first part of our lecture, the first part of our lecture is doing a predictable root canal treatment. Okay, so now it's gonna be like a summary for everything. Okay, I turned off the music so I can talk, so you can hear me while I'm talking. Okay, first of all, let me take a sip of Red Bull. I'm not doing an advertisement for Red Bull. However, if they want to sponsor me, you can do it whenever you want, because I drink a lot of Red Bull. It's taking all of my money. Okay. The first step is to completely remove all caries. Okay? You have to clean the tooth very well. You have to clean the tooth very, very well. Okay? We're not doing any partial caries removal. You have to remove the caries very well. Even in this case, we had exposure from the buccal side, but I'm gonna do my access from the center of the tooth. This way, I'm gonna have control over anything. I still have yellow dentine. Yellow dentine means that I didn't enter the pulp chamber yet. Okay? The first indicator of a drop in the pulp chamber is to have a color change, either a grayish color, like now, for example. Okay? This is when you're gonna know. This is when you're gonna know you entered the pulp chamber here. Now I know that I'm inside the pulp chamber. Or you're gonna have bleeding if it's inflamed. I'm gonna detect my probe. Okay? My probe is my visual aid. Okay? Other than my magnification. With my probe, I'm gonna start, as you can see here, I'm gonna start by doing irrigation from this point. The irrigation starts from this point because the irrigation is gonna dissolve the coronal pulp tissues. Okay, it's gonna help me identifying the canals and everything. Okay, and as you can see, the sodium hypochlorite started eating away the pulp tissue because it eats away the organic components of the canal. And I'm gonna detect the roof using the endoprobe. As long as I have roof, I still have to completely remove the canal. I move with my stone in a lateral direction without touching the floor. Okay? And I keep on irrigating and checking with the probe. As long as I have a catch, it means I didn't do complete deroofing. So I keep on doing complete deroofing, okay, to reach a full access cavity preparation. I deroof a part, then I do irrigation. Okay, I check with the probe. If the probe still doing catches, I have to deroof. Why I have to deroof? Because sometimes the probe, it has, sometimes the roof, it has pulp tissue beneath it. It can go later and go make your root canal treatment fails due to coronal leakage of bacteria, because you still have remnant pulp tissue above your gutta perca or within your composite restoration. Okay, I'm doing irrigation. As you can see, we are doing a massive irrigation in the access cavity. Now it started dissolving the tissues inside the canal. It's gonna do something called champagne bubble appearance to help you detect the orifices of the canals. Okay. Then we're gonna do access refinement via ultrasonic. The ultrasonic tip, diamond coated ultrasonic tip, gonna remove the roof, covering the orifices and covering the canals. Okay, why did we pick the ultrasonic here? Because as you can see, the ultrasonic is gonna help you visualize the pulp chamber and the canals. If you use the stone, you might perforate, you might do an overextension, but the ultrasonic is gonna help you out to work smoothly without doing errors, such as overextension, such as, for example, perforations or anything. Okay. Now you can see we have a straight line access on the canals. I can see the distal canal and I can see the two canals in the mesial system. Okay. And we work with ultrasonic with no coolant, only 10 seconds with no coolant. Then we put irrigation or we open the coolant, okay, to decrease the heat generation. Okay. After doing this, we do a proper irrigation. And after proper irrigation, you can see now we have a clear visualization of the canals and the floor. Okay, with the probe, I'm gonna detect the orifices, not with a file, with the probe. After detecting the orifices with the probe, I'm gonna start with the orifice opener. The orifice opener, as we said, continuous rotation, anti-curvature filing on the outer wall. So this is the mesiobuccal canal, anti-curvature filing on the mesiobuccal wall. If it's a mesiolingual canal, it's an anti-curvature filing on the mesiolingual wall. Look at the motion. I'm entering the canal, then I'm doing brushing motion on the outer wall. Okay? And take care it doesn't reach far inside the canal. You have to clean it with a gauze with alcohol and check the flutes. Do irrigations. Okay? Work with irrigant inside. Now we're doing the mesiolingual canal. The mesiolingual canal and brushing action on the mesiolingual wall. Okay? It's gonna transform the canal. Look at me from this direction. The canal originally is like this. Then it's gonna be like this. The canal, after removing the dentine covering the orifice, is gonna be transformed into a straight line access kind of canal. Okay? Now we're gonna do heavy irrigation inside the canal, and after the orifice opener, the picture is gonna be very clear. You're gonna have 3 canals and straight line access. If you're not gonna proceed manually in this case, this is when you take the full working length of the case. You take the full working length of the canal after orifice opener, not before, because the working length changes significantly. Okay? After this, we're gonna do, you can see the sodium hypochlorite started to eat the pulp tissue inside the canal. Okay? After doing this, we're gonna proceed with the glide path rotary file, 15 tapers 3. On SSGP motion, look how it's moving. 4 cycle counterclockwise, clockwise, sorry. then 4 cycle counterclockwise. We're gonna move picking motion inside the canal using the dual function. Okay, I don't care about the rubber stopper now if I'm using manualist. The dual function is gonna stop me once I reach the apex. So it's gonna keep me having faster workflow. Okay, and you can use the manual file if you don't want to use a dual function or purely manualist motion. The manual file is very important too for patency. So this is the SSGP motion, a safe glide path kind of motion. You can see it's a little bit slow, but it's very safe. It's very safe. And I'm gonna proceed till I reach the full working length. You can use the manual file for patency and irrigation in order to make your case completely safe. However, I wanna tell you something. This is the scouting, as you can see, it took the shape of the canal. Okay, I wanna tell you something. When you use a dual function device, you rarely do an apical blockage because you ensure that every single time your file is reaching the full working length. But make sure, dual function devices are very tricky. If there is any kind of contamination, it's gonna give you an early reading. That's why you have to make sure that the canal is dry, or you can keep your sodium hypochlorite confined within the pulp chamber. Don't make it overflowing, okay? After doing a reproducible glide path, SSGP or ATR inside the canal, and as we said, high speed, 500, and minimal torque, it's time to do the shaping now, using a 20 taper 4, okay? On ATR, adaptive torque reverse. So the file now is proceeding on rotation. When it reaches resistance, look, it's gonna turn into a reciprocation motion. Look, look, look. It's reaching reciprocation motion. Can you see now? There you go. Reciprocation motion. Reciprocation motion. Rotation, and when it reaches resistance or anything, it turns into reciprocation motion. And the sodium hypochlorite inside the canal is acting as a lubrication and disinfecting the canal at the same time. And by the way, let me tell you something. When you are introducing the sodium hypochlorite while instrumentation, it doesn't only do lubrication. The high speed of the rotary file actually makes some kind of activation of the sodium hypochlorite. So your motion now is lubrication and activation and removing the organic tissues, and you're doing everything. This is how you achieve a maximum result of sodium hypochlorite, and very efficient shaping protocol, and it's very safe as well. Okay? Now we are doing the 25 taper 4 and the 25 taper 6. And I told you when to pick 25 taper 6 and when to do 25 taper 4. As you can see here, it's doing reciprocation when there is resistance, and when it enters a curve or something, an example. Okay. This is a microsuction. I don't know if you noticed now. Before obturation, I do a microsuction. Look again. The microsuction, I entered in the mesolingual canal and it took the solution out of the mesobuccal canal. This is an indicator that these canals have communication, either a type 2 or an isthmus in between. Okay? Here is the master cone selection. We have to make sure that the master cone has tuck back. Look, it has tuck back. Okay? In order not to go through the apex while instrumenting the canal. I apply pressure using the tweezer, okay, and make sure it has a tuck back. And for easier application inside the canal, sometimes I pre-curve the geta perca in order to make it go inside the canal in a good way. Our irrigation protocol is going to involve activation. This is the sonic activation, okay? And as I said, the sonic is really good activation method because the polymer tip is going to go through the curved anatomy. However, the sonic has a flow. It makes the irrigation go out of the canal. That's why sometimes I make my assistant hold the suction and keep on applying sodium hypochlorite while I'm activating the canal. Okay? This is the sonic. Okay? The ultrasonic, however, the ultrasonic motion, this is the ultrasonic motion. It doesn't distribute the irrigant outside the canal. It confines it within the canal. Actually, on paper, it's more effective too. On evidence-based, it's better Okay, but as I said, it has limitation. So in some cases, it won't reach the full working length. And we said that the working length should be shorter than the apex with 2 mm. Okay, so now you saw the sonic and ultrasonic. We're gonna show you now the intracanal heating. Okay, we're flushing the debris. We're gonna try now the intracanal heating as well. So you can see all the method we talked about. This is the intracanal heating using the heat carrier. Okay, and we only do it with sodium hypochlorite only for 5 seconds. You can see the sodium hypochlorite boiling inside the canal. It's boiling inside the canal. It's very effective, by the way. It's very effective in cases with remnant pulp tissue. Okay, it's very, very effective. So this is our irrigation protocol and the editor and everything we said. Okay, we're gonna do now the obturation. I'm gonna show you the 3 different type of obturation we talked about. Continuous wave obturation technique using resin sealer, single cone obturation using bioceramic sealer, hot modified technique using bioceramic sealer. The resin obturation using continuous wave obturation using resin, the canal has to be extremely dry for the resin to be perfectly adapted on the canal. So we're coating the canal and we're gonna adjust our heat carrier to cut through the getaperca and leave only 5 mm getaperca at the apical 1/3. And your heat carrier can be on 250 degrees heat because the resin is heat friendly. Okay, so we're gonna go through the getaperca, leave only 5 mm getaperca at the apex. Okay, then we're gonna compact it well, as we saw in the video. We are repeating it again in order for you to memorize the steps. And with the plugger, you have to perfectly adapt the getaperca at the apical part. Okay, so this is the getaperca of the master cone, only 5 mm at the apical 1/3. Okay, and after making sure it's perfectly adapted, we're gonna introduce the other device, the getaperca fill device, in order to fill the getaperca with soft getaperca. The idea is to place the filler inside the canal to touch the old getaperca in order not to make any air bubble inside the canal. Okay? And do it on waves. Don't do it on one shot. Do a small increment, 2 mm, compact it, then another one, then compact it till you reach the orifice of the canal. Okay? So this is continuous wave obturation using resin sealer. Regarding the mesial canals, we're gonna try. This is a bioceramic sealer now. As you can see, the sealer came out of the other canal because it's type 2. We're gonna do one hot modified and we're gonna do one single cone. Single cone, I'm only gonna depend on the sealer and cut the getaperca on the orifice level. Okay? The hot modified, I'm gonna go inside the canal only for 10 mm to make sure I leave half of the getaperca, half of the canal obturated with the getaperca and the bioceramic sealer, and I don't allow any heat transmission to the apical part. Okay? And the rest of the canal is gonna be by the injectable getaperca. Okay? So this is single cone, and this one we're gonna go through the canal. Okay? But we're not gonna leave only 5 mm. La, we're gonna only leave half of the getaperca, half of the root. Okay? And the other half, we're gonna do it by injectable getaperca. And as I said before, we're gonna make the heat carrier maximum at 150 degrees in order not to ruin our bioceramic sealer. Okay? Because even if the newer generation of the bioceramic sealer are heat friendly, still you shouldn't increase the heat of the heat carrier device on 150 and maximum 180 degrees. Okay? And you should also keep the working time of the heat carrier device minimal. So this is the simplified workflow of endodontic. This way, before proceeding with the retreatments, this way, you're gonna have an advanced method of shaping and obturation, and still it's simple. And this way, you're not gonna be falling behind using the advancement of the rotary files and the motion and kinematics we have nowadays. Okay, let's finish the presentation with the retreatments. Okay, the retreatments, I made it in the form of Q&A. Causes of root canal failure. Before proceeding with the retreatment protocol, let's talk about the causes of root canal failure. First of all, is a missed anatomy, something like an MB2 minor or a major, like a radix, for example. On this tooth, it's a completely missed root. Okay. We can also have a short getaperca or overextended getaperca. Okay, overextended getaperca is gonna make an over apical periodontitis. Short getaperca is gonna leave remnant pulp tissue and is gonna make a periapical infection. Inadequate cleaning, if you're not using rubber dam, you're not using a disinfecting solution, you didn't clean the isthmus. Okay, improper coronal seal. Improper coronal seal is as much as important as the apical seal, by the way. Many cases of good root canal, they fail due to a bad coronal seal. Persistence of bacteria, that's why sometimes we go for endosurgery. It's very common in upper anterior and lower anterior. Unsolvable complications like broken file ledges, silver points that you couldn't retreat properly. Okay. And vertical tooth fracture. And in these cases, we go for extraction, not retreatment. Okay. When to retreat? If you have a poor looking root canal, like the other slides we talked about, this is a reason for you to retreat. If you have a good root canal, like the X-ray here, is it okay to retreat a case like this? The first question is that you have to ask the patient, when did you do this root canal? Because if he did the root canal within 2 weeks, for example, it might be post-operative pain or periodontitis, okay? If he did this root canal 2 years ago, 3 years ago, 1 year ago, or anything, okay? At this point, and he's symptomatic, you have to ask him. You have to ask him the history. When did you do it? Did you complain from it before? And you have to ask a CBCT X-ray because in the 3D, you might have a missed canal, okay? And the third option of retreatment is the absence of coronal seal. Because even if you have a good root canal treatment and the patient came for a crown, for example, or a coverage on this root canal, and it had a poor coronal restoration, you should retreat the tooth before doing a final restoration. Because after doing a proper final restoration, he's going to turn symptomatic and the root canal is going to fail. On the other hand, if you had a patient with a periapical passosis, okay, and this periapical passosis, and he came asymptomatic, should you retreat this case? Okay, you have to ask him first, when did you do this root canal? If the root canal, he did it within 6 months or even less, he might be in a healing phase. This radiolucency and passosis will be resolved after a few months. And actually, it can be a scar. It can stay like this for a while. It can stay like this for 3 years, 5 years or something. That's why you have to ask him if the root canal is lasting for more than 3 years, 4 years, 5 years, 6 years, and he's asymptomatic and the tooth is highly functional, and it looks fine on the X-ray. It has no missed canals or anything, and the coronal seal is intact. Actually, you can leave it. You shouldn't retreat a case like this, okay? The steps of the retreatment is that you should remove the crown first or access through crown in limited cases. If the crown is good condition, it's bonded, it doesn't have any leakage, and so on. You should remove all the decay, undermine tooth structure, and determine the restorability. Make sure there is no crack, determine the restorability before proceeding with the retreatment. Remove all the restoration, remove all the fiber post, metal post. Then start by removing your getaperca and dealing with the error, whether it was short, overextended, you have a ledge, you have a blockage, and so on. And in retreatments, we have to increase our mechanical prep and implement a very strict irrigation protocol and a 3D obturation protocol in order to maximize the success rate. How to remove the getaperca? First of all, you have to check the soft spot inside the getaperca. If the getaperca is not soft, you can make it soft by using a heat carrier device, like the one we have in the picture now, for example, and heating the coronal part of the getaperca. Okay. Then you start removing the getaperca by two techniques. It's either you're gonna use your conventional root canal retreatment, root canal rotary device files, but you're gonna reverse the sequence. What does it mean by reversing the sequence? The first file you're gonna use is the 25 taper 6. Why can't we use an orifice opener? Because the tip of the orifice opener is very small. It can break inside the getaperca. So it's better for the first file you use inside to be the 25 taper 6 and use it only for the coronal part of the getaperca. Then you use for the middle and the apical part a 20 taper 4 rotary file along with your manual files for patency. Okay? Or simply you can use a retreatment kit. Okay? This is a getaperca solvent that you can use when the getaperca is old and stiff. Okay? You can use it in cases when the getaperca is old and stiff in order not to make any iatrogenic errors. The problem with getaperca solvent that it's oil-based and it does smearing of the old getaperca on the walls of the root canal system. That's why it's very important to implement a an irrigation protocol with EDTA, okay, or citric acid in order to remove the excess oil from the dentinal tubules and many activation cycles. Okay. Here you can see I'm heating the coronal part of the getaperca. Okay. Then I'm gonna introduce the 25 taper 6 to remove the coronal part of the getaperca and the middle part too, because it's a straight canal. Okay. And I'm not using any irrigant in order to make heat generation enough to make the getaperca soft. And for the middle and the apical part, I'm gonna use the 20 taper 4 getaperca, 20 taper 4 rotary file. 20 taper 4 rotary file to remove the getaperca from the middle and apical part. Okay. Okay. This is how to do a retreatment using conventional rotary file. Usually, I don't like to use retreatment kits. Okay, I rarely use retreatment kits because most of the retreatment kits are very stiff. They can easily break, they can easily make lateral perforations and iatrogenic errors. That's why it's very rare for me to talk about a retreatment kit. Okay, one of the retreatment kits I like to use is the Retreat kit. I will tell you why. Because the Retreat kit is highly flexible and it's very safe and it's made in a very smart manner. That's why I always say it's one of the smartest retreatment kits available in the market. It's gonna help you doing retreatment and shaping at the same point. Let me show you. It comes in 5 files. The first file, it's called Bully. It's 25 taper 7. And you can see it's similar to what I was telling you before. I was telling you before that my first file is 25 taper 6. But this one is smarter a little bit. The cross-section of the files allows the getaperca to move in an upward direction. So it will make your getaperca to be cleared in a coronal direction. And it's shorter, it's longer than the orifice opener, but still it's not the same length as the other files. So it's better for initial penetration and removal of the getaperca on the coronal part. Okay? And it has a 25 tip size, so it's gonna be able to go through the getaperca without deformation. Okay? So we're gonna use the Bully for the coronal part of the getaperca removal after heating the getaperca with a heat carrier to make it go even smoother. Then we're gonna use the Skinny. The Skinny is a 25 taper 4. The Skinny is a good file, silver file, used to go through the getaperca in the middle part and the apical part. It's not used for shaping. It's used to create a pathway. Take care. This file is the weakest file within the file 5 files, by the way. So don't apply massive pressure on it. It's only used to create a space within the middle part and the apical part within the gutta perca and remove it as well. At this point, you should introduce a file manual to make patency and take working length. Or you can use a dual function rotary device to tell you when to stop. Then we're gonna start the Shapey 1, Shapey 2, Shapey 3. Shapey 1 is 25 taper 5. Shapey 2 is 25 taper 5. Shapey 1, sorry, is 20 taper 5. Shapey 2, 25 taper 5. And Shapey 3 is 30 taper 5. Why they are taper 5, not taper 4? Because in retreatment, you need to increase your mechanical preparation. And in retreatment, you need more taper to withstand stresses and not to allow the file to be deformed inside the canal. Shapey 1, Shapey 2, Shapey 3 are made of very flexible metallurgy and at the same time, a very smart cross section. Okay. And at the same time, they can withstand the shaping inside the canal. They are stronger than the skinny. That's why the skinny is only for negotiation. The shapy is for shaping and the preparation of the canal and removing the excess gutta perca and cleaning the canal system and so on. Okay? So you have two techniques now. You can use any rotary file you have, like the MG3 files, for example, and use it in reverse. 25 taper 6, 20 taper 4, and glide pass for the apical file and so on. Okay? Or you can use the retreat kit and they have the same concept, but they are more specific for retreatment. And I can personally say they are the smartest, one of the smartest kits in the market. I tried them for a really long time. And for the past years, I had very bad experience with retreatment kits. Without mentioning any names, they are so stiff and they make iatrogenic errors. So this one is personally one of my favorites. Okay? So Shapey 1 is 20 taper 5. Shapey 2 is 25 taper 5. You can stop at Shapey 2. Or you can increase it to Shapey 3. You don't have to use Shapey 3 in all canals, by the way. You can use it if you want to increase the working length. And here, we used it in this case. This case had a retreatment. I removed the crown, I removed the restorations, I removed everything. I determined restorability, and I proceeded. This case shows how well this kit is. I will tell you why, because you can see in the preoperative X-ray, the apical part of the canal had dystrophic calcification. You didn't have a root canal space in the apical part. So I started by the bully to remove the coronal part and part of the middle part. Okay? Then I started proceeding in the middle and apical part. And let me tell you something I did in this case. I added on the gliders, I added on the retreaty, I added gliders as well. The gliders, the pathfinders I showed you at the first of the presentation to negotiate the apical part. I used only one. I used only one file, the 10 taper 5. For me, this is a genius file. Okay? And I finished the shaping and I added an extra file on my shaping protocol, which is the XP shaper, in order to remove the excess gutta perca on the walls. And then I did obturation using hot modified technique, bioceramic sealer and hot modified technique in order to do a 3D obturation technique. What is the difference? The shaping protocol, now you have it. I use the retreaty or even the normal rotary files in the reverse action. The difference in irrigation protocol and obturation, in obturation, I usually go for hot modified technique or even single cone, but mainly I want bioceramic sealer in retreatment cases to maximize the success rate. In my irrigation protocol, I tend to activate more using sodium hypochlorite, doing different activation method. I can combine actually intercanal heating with ultrasonic. I can combine activation using XP finisher, for example. I can do many irrigation protocols, many irrigation cycles, I mean. And sometimes I can put calcium hydroxide for 2 weeks to make sure that I reach the maximum disinfection before obturation. And even sometimes in resistant cases, I can put chlorhexidine as my final irrigant. So the irrigation protocol is the same, except that you have to be more, let me say, OCD. You have to take care of the tiny details, because in obturation, the success rate is lower than the first time you do root canal. When you do a fresh root canal for the first time, the success rate is more than 90%. When you do a retreatment, it drops down to 80, sometimes to 75%. So you have to maximize the success rate as much as you can. And in retreatment cases, sometimes the apical part due to infection has resorption. That's why you have to learn how to make an apical plug in a smart way before obturation. After complete cleaning and shaping, okay? If the apex of the tooth is more than 60, I don't obturate with conventional getaperk. I obturate the apical part with MTA or bioceramic putty, whatever your technique. I place MTA at the apical part and I pack it. I pack it with getaperka, with a plugger, with a bond brush, whatever the technique you want. Then I inject the canal with soft getaperka. So in obturation, in retreatment cases, I can go as far as doing an empty apical plug to ensure that I can reach the maximum success rate. Okay? So in retreatment cases, sometimes you can have a resorption in only one canal. Like, for example, a palatal canal in this case. This case, I can do it with the empty apical plug, and the rest I can do them with single cone and hot modified technique. But I would go for bioceramic sealer in retreatment cases in literally all the cases to make sure I can reach the maximum success rate. Okay? Let's see this video. This is a retreatment case. Okay? I started by coronal heating of the getaperka to make it soft. And then I went through it with 25 Tipper 6. Then I continued the shaping protocol using dual function to help me out when to stop. And here, as you can see, I'm removing the excess getaperka using a micro tweezer. And the excess getaperka on the wall using XP shaper. I'm using multiple systems to remove the getaperka. Okay? The excess getaperka from the walls. And I'm removing the excess getaperka from the isthmus between the MB1 and MB2. And I'm doing sonic activation and intracanal heating. And now I'm doing microsuction inside the canal. And I'm gonna start the obturation. This is the master cone X-ray to make sure everything is good. I did single cone obturation for the MB1, MB2, and distobuccal, and for the palatal canal, because it's big, I did hot modified technique. So I combined two obturation technique in one case. This is the take-home message that has everything we said in the lecture summarized. I'm gonna keep it for a while in order for you guys to take a screenshot or even take a picture of it. This is the protocol of shaping and the protocol of retreatment we did. Let me go through it again. Just shaping protocol, you found me shaping the canal using MG3 blue files, and for glide pass, I used gliders, okay? The orifice opener on continuous rotation motion. The glide pass file, either the 15 from MG3 blue or the gliders, we're gonna use them on SSGP motion or ATR motion. Then the shaping files, the 20 Tipper 4, the 25 Tipper 4, the 25 Tipper 6, even the finishing files, 30, 35, 40, on ATR motion. And we set the parameters, always go on high speed, 500, and the minimal torque you can, that doesn't bother you. Some people work well with 0.6, some people work well with 0.4, some people work well with 1, okay? But I usually go for torque less than 1. This is the shaping protocol we talked about today. And we said always work in the presence of sodium hypochlorite as a lubricant. The retreatment protocol We're gonna do the retreaty files. The bully is for the coronal part. And I said a clinical tip, it's better to soften the geta perca using the heat carrier before using it. The skinny for the middle and the apical part, and don't force this file. Be soft with it. The shapy one, shapy two, shapy three for the apical part of instrumentation, okay? And enlarging the canal and final shaping. This retreatment kit is more than enough, more than enough. You can add on it, for example, XP shaper, XP finisher. You can add on it irrigation protocol. Anything extra on it is going to be only for cleaning the walls of the canal from any excess remnant partition. But this kit is more than enough for you to finish a retreatment case from A to Z. Okay? And we talked today about the manualist preparation using the EndoMaster device as well. Okay? So you can follow me on my social media accounts. Okay, this is the QR code of my Instagram account. I will be always there to answer any questions. And this lecture is recorded for you to keep on hearing it. And if you have any questions, we can get back to you and answer your questions. And I always say that a predictable result is not achieved by a complicated protocol, but actually a simple protocol that you perform consistently. Okay? So I hope you enjoyed the lecture, and we did it exactly in 1 hour and 30 minutes. I hope you enjoyed it, and thank you, D Perfect, for allowing me to do this webinar and share my passion. And thank you for the amazing products. I rarely speak of using any product with anyone, but you actually, guys, you deserve the best. You are one of the best companies out there, and you actually give good products, and they are highly sustainable. So it's an honor, and thank you so much for everything. And hope to make webinars with you soon again. Thank you so much.
Okay, thank you so much, Dr. Khalid, for your informative and very interesting webinars and presentation. So
Thank you so
could
much.
you could you stop sharing screen?
Okay.
Okay.
Nice to meet you guys.
Yeah. Just wait a bit. Okay. So on behalf of Perfect Company and the OS10 Endo stores, we would like to say thank you so much for your informative presentation. I can say that we so enjoy and we're so happy to see your good presentation, and it's so informative for us. So we also send you the e-certificate of uh, your time for your sharing and tip and trick in endodontic practice today. So I will send you the PDF file, Dr. Khalid. And we have few questions on the message.
Thank you so much. Yes, I'm happy to take the
Yeah,
questions now. You can hear me right, sir?
yeah, so okay. The question: in case of retreatment, what should be the speed and torque for the file?
I can't hear you now.
Mhm. You hear me? Uh, there is a question in the message. Do you hear me? Dr. Khaled, do you hear me?
Can you talk again?
Do you hear me?
Now I can hear you. Sorry.
Okay. Okay. There is a question in message. In case of retreatment, what should
Mm.
be the speed and torque for the file?
Actually, I would go for the same speed or even higher. 500 is good enough. Usually in retreatment, we
So
increase the speed more than the shaping files. Due to it will do some kind of heat generation and it's gonna help us remove geta perca faster. Okay, but I already use a high speed on shaping, which is 500. So yeah, I would use in retreatment cases. Sometimes I use 500, and if it's a straightforward case, I can use a 550 or even 600.
oh, I see. How about the torque? You still use the low torque in retreatment
Low
can with
torque, in
retreatify?
retreatment, I increase the torque. I increase the torque to 1.5. I don't increase it more than this.
I see.
But actually, in retreatment, sometimes I do retreatment on ATR motion as well, not on continuous rotation. Because a good thing, it's a good question. In ATR motion, when the file is subjected to stresses, it turns to reciprocation. Reciprocation motion is a good motion for getaperca removal. It removes getaperca better than continuous rotation, actually.
So in case of no gutapercas in they can also can we use the retreatify or do they have
Yes,
the
exactly.
other technique?
That's why I say that that kit is very smart. This kit is very smart because it combines both things. Usually, the old retreatment kits, other than that, they are very stiff and they make iatrogenic errors and problems. They can actually break inside, or they won't even do the complete shaping. The retreative files, they remove getaperca and actually they do shaping. That's why you can finish the case only with retreating. That's why I like them. That's why I say it's a smart kit. Usually I do retreatment by reversing the normal rotary file kit. It removes getaperca and it does shaping. That's why I like retreating kit. Retreating kit, it does the both.
Yes. Thank you for your answer.
You're welcome.
And the other question from Hazem Ali.
Yes, I see it. You rely on
Yeah.
manualist
Yeah.
preparation even in complicated anatomy? If yes, can you provide the protocol? Yes, I do rely on manualist preparation, providing that you have the tactile sense of the rotary file inside the manual, the rotary device. If you can feel the rotary file inside the rotary device as if you are doing manual preparation as well, this is when it's a clear sign for you that you can switch to manualist preparation. Manualist preparation in complicated anatomies, I can show you many cases with a 90-degree curvature and everything. I did it with manual preparation. However, the protocol is very simple. It's the same protocol I did in the lecture, by the way. But you have to be smart in picking your glide path files. Because if you did the case, you did a reproducible glide path, I can ensure you that you won't have any complication in the case. You can even use two files for glide path, 10 tipper 5 and 15 tipper 4, for example, to make a reproducible glide path. And you have to be very picky. You have to check the file, check if it's unwinded, check everything, work in the same manner I explained in the lecture, and to use a good device Like, for example, the Endomaster use a Morita device. You have to use a very good rotary device to help you out, and you can use it on a high speed, as I said, minimal torque. You should practice on extracted teeth at first, and you're gonna love it. It's one of the best techniques. This is how I teach even in my courses. In my courses, I teach them how to do a manualist preparation. But at first, I ask them to add a file 10 for them to feel the canal, for scouting, for an initial glide path preparation before I make them do a completely manualist preparation. But I can even remember the last time I used even 515 manual.
Yes, the other question from Ariane.
Yes, want the high speed create more pressure on the rotary file during the, actually no, actually no. Actually in retreatments, we increase the torque as well because we need to apply a little bit of pressure to go through the gata perca. Okay? The pressure on the rotary file, the risk actually is from your hands, not from the high speed. The high speed is gonna make the gata perca gets removed faster, okay? And it's gonna decrease the contact points on the rotary device. The only problem with the high speed is that it can get screwed inside the canal. So you have to control your rotary device not to be slipped while you're doing the instrumentation, okay? And not to apply excessive pressure on the rotary device, okay? The next question, any particular motion technique to bypass the ledge? Actually, the ledge, this is when you should rely on manual instrumentation, okay? This is when you should rely on manual instrumentation. However, you can use a glide path rotary file and pre-curve. Most of the rotary files now are control memory. If you give a pre-curve to the file, it can maintain the shape. So you can use a tweezer, pre-curve, do a sharp bend in the last 2 millimeters of the file, and put it in the inner wall of the canal. This is a very, very advanced technique. Put it inside the canal and do the SSGP motion, the reciprocation motion. This way you can bypass the ledge using a rotary device, but it's very tricky and it's very advanced. So regarding bypassing the ledge, I would refer to an old school manner by using a file 10, file 15, manual, sharp curve, and do it till you get very advanced in endodontics. This is when you can use a glide path rotary file and do what I'm telling you. Okay? What are some of the ways you use to determine when to change the file to prevent? Yes, exactly. This is a very smart question. Many doctors, they number the rotary file. It worked 1 canal, 2 canals, 3 canals, and this is not predictable, by the way. This is not predictable because not all the canals are the same. Not all the canals are the same. You can work 30 canals, straightforward, wide canals, and you can work only 1 canal with a narrow anatomy that will literally destroy your file. So I determine the chances of the file being separated in the future by visual examination. And by the way, I check my file between each canal and even in the same canal. For example, if I'm instrumenting a hard mesiobuccal canal, between I do 1 stroke, 2 stroke, then I take the file out, clean it with a gauze with alcohol, check it under magnification, and see the flutes. If the flutes are unwinded, this is when I discard the file and go with another file. Sometimes a hard canal can take up to 3, 4 new files. This is not something wrong with your technique. This is a hard canal, okay? You're welcome. Recommended book for endodontic for fresh graduation, and thank you, Doc. Okay, you can actually Pathways of the Pulp. I guess this is the book I started. This is actually the first book I started reading. This is my favorite book, actually. Pathways of the Pulp by Stephen Cohen. This is my favorite book, actually.
Okay, I think it's time to finish the webinars. So,
Thank you so
uh,
much.
yes, our participant, if you have question, please ask directly to Dr. Khalid in IG or Facebook or his contact. So finally, we would like to say thank you again for your informative
Thank you so
presentation.
much.
Yeah, and I think we do enjoy your presentation. Such amazing presentation for me today.
Thank you so much.
So yes,
Thank you
thank
so
you
much.
again for your time. Yeah,
It's my honor and thank you
yeah,
so much. Thank you so much. Looking
yeah,
forward to
yeah,
meet you soon.
yeah, yeah,
You're
yeah,
welcome.
yeah. Goodbye,
Bye
Dr.
bye,
Khalid.
guys. Hope you
Bye
enjoyed
bye,
the
bye bye.
presentation. Bye
Yeah,
bye.
thank you. Yeah.